Let's see. So we're gonna do Menti.
I'm in it.
There we go. So if you aren't in yet, go ahead, either scan the QR code, go to menti.com, enter the code.
Yep.
If you get kicked out of the Menti, something happens, you can go back in. Just know, go to the menti.com.
I didn't.
And then what's our code today? Will somebody read it for me?
44.
44? Great. And 8. Okay. So if you get kicked out, that's how you get back in. All right, if you're in, go ahead and give me another reaction so I can see how we're all here or how many people are all here. I do like to use these reactions during the class. Please feel free to raise your hand, ask a question. Some people don't like doing that. So if you put a little question mark reaction, that lets me know that somebody maybe has a question, but they're not super confident asking it, lets me know to kind of try to go back over. I don't always see the reaction. So, if somebody sees like, hey, there's a question, just, help me kind of look out for those. All right, I'm going to move forward. Maybe. Oh, well, fiddlesticks. Is it not going to work? Try something else. Yes. World. Okay. All right. Well, I got to use the clicker. I don't like that. It means I can't move around as much. Okay. So just to teach you how to use a Menti, we're doing a little fun thing. So this lets you pick options. It shows a little bit of what we do in class. Not this, but So this or that. What would you choose? A puppy or a kitten?
Oh,
Yep, you got to choose on your device. The cat emoji, somebody's trying to do extra. Yeah, now you're wondering why. Why are we doing this? All right, so let's go to our next one. Who would you rather have lunch with? I'm curious. Tim Burton, Michelle Obama, Doctor Who, Florence Nightingale, C.S. Lewis, or Taylor Swift?
As long as her boyfriend comes with. Double date, let's go.
Super fun.
That's not what I thought about.
Oh, so we do have a Doctor Who fan.
Oh.
Yeah. No. I took a literature of C.S. Lewis class when I was in school, and it was really fun.
Okay.
All right, so maybe a few more Doctor Who fans. All right, I'm gonna move on. What about this? What's your favorite type of sweet? Licorice, chocolate, sour, maybe fruit? Or are you a crazy person that doesn't like sweets? All right, let's see. I think I have another one. How are you feeling today? I think you can put up to 3 responses on this one. It's a word cloud, so it kind of gives a general of how we're all doing. I like the background music. Okay, we got a lot of tired people today. Little tense, stressed, sleepy, tired, cold. Well, crazy. Yeah, numb, motivated, ready to learn. I like it. A little overwhelmed. And so just to speak to the overwhelmed piece, our brains are very amazing things. When we're introduced to a lot of information at once, it is very overwhelming. Please give your brains time to adjust because you will adjust, you will get it, you'll get through it. It doesn't feel good, right? Growth is uncomfortable. Anybody remember when they were growing, when they were small, like remember the growth pains, like feeling like your bones grow? I still remember that was painful. That hurts. But it was with purpose, right? The purpose was to grow, help you become who you are. And so it's uncomfortable growing and learning, but the purpose is to help you grow into becoming a nurse. So if you can embrace that growth, that painfulness a little bit, because you'll get through it. It'll be all right. Okay, let's move on. Some days I won't do this, but today I want to really quick before we jump in. I like just to do hands held, scale of 0 to 10. 0 is you are confident about critical judgment, clinical, critical thinking, or 0 is nothing at all. 10 is I feel really confident. How are you guys feeling about it? 10, 0, middle. Okay. Well, we're doing me. Okay. All right. So let's just talk about it because you guys talked about critical thinking, clinical judgment a bit already. So let's talk about the why. So thinking about nurses, new graduates, what percentage of them that are able to practice safely? Put it on the Menti. No, you're good. It always happens. All right, and the answer is indeed 23%. They've done studies that show nurses, when they graduate, only about 23 really have that ability to practice safely. What does that mean? Let's talk about that a little bit. So it has to do a lot with their thinking. So good thinking is important because you want to make sure that when you're taking care of your patients, you're able to recognize, hey, this is abnormal, right? When we're doing physical assessments in the lab, we want you guys to identify the normals because when you know what normal is, abnormal is going to stick out and you're going to know like, hey, I maybe don't know what that is, but I know it's not right. You want to make good and quick decisions, right? In nursing, and just healthcare, patients can decline really fast and you have to make fairly quick judgment calls. And you want to avoid failure to rescue. Failure to rescue is if you have a patient that's declining, not doing well, and you either don't recognize the symptoms, you're not confident to speak up about it, or you're not quick enough in responding, that patient might decline even further because you're not stepping in and helping them. Critical thinking. Critical thinking is a strategy that helps you get to a good outcome. It helps you understand what's going on with the patient and the why. Why is that happening to these patients? The what's up mnemonic is really helpful. Have you guys used this at all in foundations? Not so much? Okay. So when something's happening with a patient, you want to go through what's up. You want to say, where is it, right? Where in the body, what's happening? How does it feel? Describe it for me. You want to say, are there any aggravating or alleviating factors? That means aggravating, what makes it worse? Alleviating, what makes it better? Timing, is this problem always going on constant? Does it come and go? Is it always at night maybe? Severity, how severe is this? Is this like really bad or you feel like, yeah, it's kind of an annoyance? Ask your patient, is there useful other data? You're like, hey, they're complaining of, urinating all the time, but they're also taking their Lasix, they're urinating at night, but they're taking their Lasix right before bed with their bedtime medication. That might be useful information for us. And then patient's perception of the problem. What does the patient think? Even though we might study the human body, physicians, people study all about medicine, we don't know somebody's body as well as they do. So please listen to your patients because they've lived with their body and they know their body a lot better than we do. And so let's give them some credit. I want you guys to turn to each other. So just partner with somebody. And I want you just to go through and just pretend, just really quick, something's going on. Let's just say that somebody's having pain in their toe. Okay. So I want you guys to ask each other really quick, like go through the what's up mnemonic.
Have you been taking Alright. Okay. Scale of 0 to 10. And how long?
Okay.
Any other?
Then how long have it when did it start?
Like what critical?
And then. Oh my Anything else?
Okay, let's wrap up. So what's up? It's a good little mnemonic to use when you're assessing your patients. It's going to help you to gather the information you need to know to make a good decision. So clinical judgment, that helps us with the doing, right? So critical thinking is the what, the why. Critical judgment is the now what do I need to do about what I've learned? You need to have good attitudes, and we'll talk about some like critical thinking attitudes or some learning attitudes. And it helps us make decisions when something's going on with our patients. Those attitudes, actually, before I say that, you guys tell me. So which attitude is being used by the nurse who says, I don't know, but I'll find out? Is that intellectual humility, intellectual courage, intellectual autonomy, or intellectual integrity? All right, and the answer actually is intellectual humility. So let's go through and kind of look at these. So one of the first one is, do I have examples on here? Oh, no, I don't. So intellectual humility, exactly like I was saying, somebody asks me, hey, why do I need to take this beta blocker for my blood pressure? I don't know. And maybe I'm like, I thought beta blockers do. I don't know. But you know what? I don't know. I'm going to go find out. Don't fake it, okay? First of all, faking it in nursing isn't necessarily safe. We want to find out the information we need to know. And that shows our patients, our peers, whoever it is, hey, I don't know everything, but I will go find out what's going on. Intellectual autonomy, that is where I'm choosing to do something that maybe is different than everybody else. Everybody else goes ahead and just documents respirations as 20 because they don't want to count. But I'm going to have intellectual autonomy. I'm going to go ahead and do this regardless of what other people are doing. That kind of bleeds into intellectual integrity, which is doing the right thing, even if it's maybe not easy, or yeah, when nobody is watching, right? I'm going to, make sure, I mean, and it gets dicey. I'm not gonna go there. But it's doing the right thing, right? My patient's pill falls on the ground. I'm not gonna pick up the pill off the ground and give it to them because I know that that might expose them to germs and bacteria and whatnot. So I'm gonna go ahead and throw that away. I might even have to, if it's an opiate, I'm gonna have to waste it with another nurse and take a lot more time. But I'm gonna do what's right, even if nobody's around to see me, because I know what's right for my patients. So nursing process and clinical judgment, they're a little bit different, but they also feed into each other. So have you guys talked about nursing process a lot in foundations? A lot, yeah, and clinical judgment? Yeah, okay. So I kind of like this side-by-side data that we have here where it kind of walks through each of them. So nursing process, that's where we're gathering data, we're figuring out what the problems are. We're gonna say, okay, we have a problem. Where do I want that patient to be? That's what determining outcomes is. My patient can't walk. Well, I want him to be able to walk 10 feet. Maybe that's my outcome. I'm going to plan how we get there, and then I'm going to implement that plan of care and I'm going to evaluate it. Clinical judgment is similar, but it looks a little bit different. It says identify and analyze the clues, so similar to gathering data and identify problems. Then I'm going to prioritize a hypothesis. My patient can't walk because he had a stroke. He had a neurological problem or event that happened. I'm going to make some solutions, right? I'm going to get some exercises for him. We're going to involve maybe some other therapies, people to work with them. Then I'm going to talk about what actions do I take and evaluate those outcomes and repeat it. So it's kind of this process that you kind of go through. This picture kind of works for some people, and it's a combination of the nursing process and the clinical judgment model, how it all comes together. It's not something that you do when you're done. Both the nursing process and the clinical judgment model, they're just a big cycle, right? Because maybe we get our stroke patient to get up and he walks 10 feet. Is that it? Is that all he ever needs to walk in his life? No, because then we're going to say, okay, now he can walk 10 feet. I want him to be able to walk to the end of the hall. Once he gets there, I want him to be able to get up and safely walk around his house, maybe go for walks around his neighborhood. You're going to always be evaluating. Maybe he can't walk that 10 feet. Maybe he gets too weak. Maybe I have to go back and think, okay, what else do we need to do? Maybe we need to add in a walker. We need to add in something else for this guy. We're always thinking. Okay, so now go ahead and look on your Menti and your screen. Put the steps in order of the clinical judgment process. If you finished, will you just put a little emoji or a like on here? Because it doesn't show me like how many people have finished already. Okay. Anybody need another moment? Moment? All right, so just to remind us, we're identifying, analyzing the clues, prioritizing hypothesis, generating solution, take outcome, evaluate outcomes, repeat. Think about if you walked into a room and there was, like in your kitchen, and there's a fire on the stove, right? You're gonna look and be like, oh, I see flames. I smell smoke. I'm evaluating and identifying the clues that are around me. Then I'm gonna prioritize a hypothesis. What happened? Oh yeah, I left my grilled cheese on the stove and left and forgot about it. So I think that's what happened. I'm gonna generate a solution. right? Like I'm gonna maybe, what do you do? Baking soda, water, or something? I don't know, but fire extinguisher, right? Best maybe. I'm gonna say, okay, I think I need to put this out, right? And I'm gonna put it out by using my fire extinguisher. Then I'm gonna take my action. I'm gonna actually put it out. Then I'm gonna evaluate. Did the fire go out? If it didn't, maybe it comes back up. I'm gonna repeat the process. So it doesn't have to be this huge hard thing. It kind of is just you guys are doing this every day, right? Something doesn't work, you're problem solving, you're figuring out. It's just about doing it in the nursing realm, and there's a little bit of higher stakes, so it is a little more stressful. What's vigilance? Go ahead and type in on the screen. Good answers, you guys. Be prepared to take answer. Awareness that moves you to action. Knowing your surroundings. Looking at your surroundings, knowing what's going on. Quick in making decisions. Oh, nice job. So when we talk about vigilance, and just like you guys were saying, it's being alert, it's being watchful. What is happening with our patients? It's also anticipating problems, right? What could go on? My patient who had a stroke is in bed, is not getting up and moving around. I know that puts him a higher risk of a stroke, of having a deep vein thrombosis, a blood clot. So what am I going to do to help maybe think ahead and help prevent those problems? You try to think about the problems as they're smaller and what you can do to prevent them before they become bigger problems. Let's talk a little bit about communication. There are some communication skills and things that we're going to use throughout class in the program. Cuss is kind of a fun one because I want you to cuss at your coworkers and your people that you work with. And cuss, it's an acronym saying if there's something that you don't know, that's okay. Go find somebody. I like to tell my students all the time, it's okay to be nervous. When you are out and practicing in clinical, when you graduate, you're going to be nervous a lot. There's going to be things that happen. You're going to identify something that's abnormal and you're going to go, I don't know what it is. I don't know what to do. That's okay. That's what we want you to do. That's what a beginning nurse should do. But don't ever be nervous alone. Students and new nurses who are nervous alone get into trouble because you don't know. You need to go get some help. So cuss means C is I am concerned. That's a key word that a lot of facilities and a lot of big hospitals or places have used as a word. If you say I am concerned, that's a key or a clue that somebody needs to get, oh, I need to actually listen to this person. Something is going on. I am uncomfortable. Yes, I did receive that order for 200 units of insulin, but I am uncomfortable giving that medication because it would kill them. This is a safety issue. Thank you for telling me this patient needs to go to MRI. However, this patient is 420 pounds and I only have a gurney that is safe for up to 350 pounds. It's not that I don't want them to have MRI. This is a safety issue. Right? Those are some words you can use when you're communicating with people that it helps you say, no, I'm not going to do that, or I can't do that. Or, it's not just shutting down, it's saying, no, there is reason. I'm using critical thinking in my decision making with this. Okay, so let's practice cuss with each other really quick. So let's say that a provider has written discharge orders for your patient, but you know they're going home alone and they don't have anybody to help her. And you're very concerned because she has a history of falling. She's already fallen once during the hospital stay and she's very forgetful. So turn to your partners again and just plan, how would you use one of the components or multiple components of the cuss acronym?
Okay, okay, okay. Okay, perfect. Oh, okay, okay.
All right, let's wrap up, just 10 more seconds. All right, how do we feel about using cuss? Okay. I'm gonna tell you now, as a nursing student, when you start clinicals next term, when you're a new graduate, it is very uncomfortable to approach somebody if you've been given a task or direction to say no, okay? That's why I want to give you guys these tools so that when you're using your clinical judgment, your critical thinking, you might not know the answer, right? You might not know, like, I should do this instead of this. But you just might know, that hits me in a way that makes me not feel good. Use your intuition. You're going to be developing a lot of skills as you continue through the program. Some of the things you're going to encounter, you're not going to know why it hits you strange, but it's going to hit you really strange. So trust that and just say, hey, I'm uncomfortable with this. Go find your resources. In clinical, come find me, come find Chuchu, whoever your clinical instructor is, talk to them, talk to your nurse you're assigned with, talk to somebody else. When you start as a new nurse, identify those people who are resources and go talk to them. But we want you guys to be able to not just do things because you're told to. That's where patients get injured, right? That's where bad things happen to our patients. S-bar. You guys use S-bar? And okay, I was pretty sure you guys have used it already. When I am training new nurses, I often will give them a little paper and I'm like, okay, it's time for you to go call the provider. Write down your S-bar and we're going to use it. When I was a baby nurse, one of my first times I had to contact a provider, and I worked at a big teaching hospital. And so we had a bunch of new doctors who were just out of medical school. So it was like their first time like being out of medical school and actually, doing the doctor thing. And I was on night shift and my patient needed Tylenol. This is a true story. And I called the provider and I said, hi, what's his name? It's Dr. Jason Wood. I still remember that. I go, Dr. Wood, my patient is hurting and I think they need some Tylenol. I don't think I said Tylenol. I just said they're hurting. And he was like, oh, okay. Give them Tylenol. I said, okay, thank you. And I hung up and he hung up and my nursing preceptor was like, huh. And I was like, oh no, what did I do? And she was like, you think he knows who you were talking about? And I was like, oh. So I had to page him back. And so I was like, oh yeah, Dr. Wood, sorry. This is Rebecca. It's patient, Sam Smith over here. He was the one who needed Tylenol. And he's like, yeah. Oh yeah. And he goes, and give them 325 milligrams. I was like, oh yeah. Like, okay, thank you. Hung up. And I was like, he said, so I hang up again. And my nursing preceptor's like, okay. And she goes, so he said 325 milligrams. I'm like, yeah. She goes, how often? So literally, right when she said that, our phone rang again, and it was Dr. Wood going, and that's every 4 hours as needed for pain. Like it was the worst communication by two people who were just, he probably had his like doctor preceptor with him going, come on, idiot. Like the same thing that my nursing preceptor is doing to me. If I had planned out a little bit of an S-bar, I think that would have gone a lot better. Unfortunately, it wasn't a critical issue.
Thankfully, he was nice.
He was as clueless as I was.
Good.
We were both,
Like
none of us
better.
But you can see if this was a more high risk or a critical issue, that type of communication doesn't do well for our patients. It's not very clear at all. So yeah, it takes a lot longer. So make sure you think through, and especially if it's those stressful conversations, if you have to question an order, if you have a supervisor that's given you a task, you're not comfortable with it, a lot of times go through and S-bar it. Sometimes that helps you realize why you're uncomfortable or what's going on. I don't want you to do the S-bar practice. Active listening. So this is something I really want to encourage you guys. When you're with your patients, be active listeners. And what that means is, yes, when you are doing your assessment, you're talking to them, you're going to get really good at your assessment, doing it for the moment you walk into the room, right? Like right now, as we do our head to toe assessment, it's kind of like, okay, I'm doing this, and then I'm doing this, I'm doing this. You're going to be able to, by the time you've been in a patient's room for 3 minutes, to have a lot of that assessment already done based on what you're seeing and what you're looking at. But when you're talking to them, I want you to focus on the patient. I want you guys to make eye contact with your patients. That's really hard when we have like a screen and we're like, talking to them and we still have to type on a screen a lot of the times. What I tend to do is I like to use a lot of scripting in my practice. When I meet somebody, I talk to them, make eye contact. Hey, my name's Rebecca. I'm going to be your nurse taking care of you today. I'll probably be here till whatever time. I go through that. And then I say, a lot of the stuff that we talk about, I also have to document in the computer. So I might be looking back and forth from you to this computer. And I'm sorry, please let me know if I'm missing something. That lets them know that I see them, I acknowledge them, and I also acknowledge the computer that we all need to use because it's part of our system. But I think that helps patients know that, I'm not just sitting here looking at a computer and not talking to them. I want you guys to verify what you hear. In nursing, we do a lot of read back and repeat backs, right? So I did this with my husband this last week. I said something to him and it was, I don't know, probably 20, 30 words. And I was asking him a question and his response back was like a very non-committal 2-word answer. And so I just looked at him and was like, I'm like, in the medical field, we use read back and repeat back so that we know what people are saying. So if I was at work and I said that, somebody would probably say back to me what they heard. And he was like, oh. And then he repeated back to me totally not what I had said at all. And I was like, oh, I'm so glad you said that because this is actually what I meant. So read back and repeat backs. We use that a lot. Like if somebody says, hey, Rebecca, would you go check the blood sugar for patient in 3 for me? I'd go, yeah, blood sugar in 3. Got it. I'm going to go do that. If I'm taking a telephone order from a provider and they say, I'm like, hey, their blood sugar was 420. And they say, yeah, I want you to give 10 units of regular insulin one time now, subcutaneously. I would go, okay, I hear you telling me for patient so-and-so, you want me to give 10 units of insulin sub-Q one time now. Like you go through and you repeat back to make sure we're on the same page. If I check the wrong patient's blood sugar, probably not that big of a deal, right? Not the right thing to do, small hiccup. If I give a wrong dose of insulin or I give the wrong patient that insulin, that actually is a much bigger deal. So it really is important that we use read back and repeat back and ask clarifying questions. I've had providers give me really dumb orders before about, what did they say? They said milligrams instead of micrograms one time. And I said, I heard you say this order and milligrams. I said, I wonder if you meant to say micrograms. And they went, oh my God, yes, please. Yeah, right. And so we're going to ask those clarifying questions and we're not going to say, hey, dum dum, but we're going to be respectful and we're going to be, because it's not that I am smarter or I know better. It's that, hey, maybe you had a long night and you just were up all night doing something and you're just not thinking, right? We're going to look out for each other with this. Prioritizing care. We're going to use Maslow's hierarchy of care. So you guys probably have all taken psychology. I think that was one of the prereqs. And so we always are going to be kind of leveling, right? Because you're going to walk into patient care and you're going to have a whole slew of patients and they all are going to have issues. And you have to decide, who do I see first? Who do I see last? And where do I see those people in the middle? You're going to go life-threatening or things that are most concerning first. You're going to go to health-threatening, things that might be kind of detrimental to their health next. And then you're going to go to health promotion next. Like who just needs they're ready to discharge, but they need their education. They need to be taught how to take care of themselves at home before they go. This is Maslow's. I'm not going to go over all of it with you. So let's do an example of this. A nurse is caring for a patient who's experiencing dyspnea. What's dyspnea? Having difficulty breathing. We're gonna do a lot of word building. Pnea or P-N-E-A, where is that? That's always like breathing lung. Okay, like dysfunction, that means it's difficulty breathing. So if they have dyspnea, anxiety, hunger, and a tremor, what problem do we address first? Thinking about that Maslow's hierarchy of needs. You guys are really good. And the correct answer is dyspnea, right? Because that is the life-threatening issue. Yeah.
Complaining about their foot and they don't really care about that much, and they're like, my foot hurts so bad, would you go with what they want you to care first? Or do you
I would always, using the what's up mnemonic, I want to get the patients, like, I want to include what they think the problem is. However, if they're visibly dyspneic, if their oxygen sats are 80, but they're complaining of their foot, I'm going to use my nursing like judgment and say, okay, the priority here is the lungs, right? That, yeah, I've got to get there because their brain needs oxygen. If their oxygen levels are 80%, that means the brain is not getting the oxygen that it needs to function. So yeah, I want to fix the foot for sure. And I might just, and I tell patients that, like, hey, listen, I'm going to help you with your foot. Right now, I got to make sure you're breathing, okay? I said, give me just a minute. And that way it acknowledges that issue with the patient, but it also addresses the more priority concern with them as well. Collaboration, super important. We've kind of been talking about it, but we want to collaborate with the whole healthcare team. I'm a big advocate for making sure that the whole healthcare team is working together, collaborating, making sure we are all for this patient. There's not just some person who's more important or less important. We all have a piece of how we're caring for these patients. Oh, false news. Where do you get your information? Tell me, what are good sources of information? These are so tiny on the screen. I hope you can see them on your devices better. I think you should be able to choose multiple choices on this, so there's more than one correct answer. It doesn't shoot. Menti like did this like reboot last term, and so just choose at least one that you think would be correct. And the choices are nursing textbook, diabetesabout.com, nln.nih.gov, mayoclinic.org, a nursing journal, a medical journal, or the ladies' home journal. All right, ready for responses? Hey, you guys got it. Good job. So a nursing textbook? Yes, that's why we said buy these textbooks, because we think that they have really good information in them. I'm going to skip over to the journals. A nursing journal, so things like the Washington State Nursing Association produces pamphlets and journals. So does the American Nursing Association. They have articles and other things that are really helpful for practice. I would trust those things. Same thing with medical journals. Those are usually targeted towards providers, but we as nurses get a lot of good information from those as well. Ladies' Home Journal is a magazine, like a fun magazine, and so I wouldn't necessarily trust that information necessarily. Looking at our websites, right? Mayoclinic.org, right? So we're all familiar with the Mayo Clinic or the Cleveland Clinic, some of these Johns Hopkins, some of these big medical organizations that are very well established. I would look at their information, you know, those they do produce a lot of good scholarly work. We also have the nln.nih.gov. If it's a .gov organization that's usually government regulated, usually means it's a pretty good source. The NLN is the National League of Nurses. That's actually a great source. We refer to that all the time in education, making sure that what we're teaching you is lined up with what the NLN has for appropriateness. There's also this diabetes.about.com. That just looks kind of sketchy, right? It's like, well, I mean, maybe, I don't know. You could look at it, but I wouldn't necessarily use that when I'm saying, what do I need to know? One of the big reasons I'm telling you guys this is I want to make sure when you're looking up information, please use good sources of information. There's going to be times you're like, man, I don't know what this is. Please don't use the Dr. Google. Like, if you have to go and look something up online, that's fine. But when you look through the diabetesabout.com or what's another common one people look up? The WebMD, like, and those are okay, right? They're not bad sources of information necessarily. I just don't know if I would trust them. When I'm Googling and I'm saying, what is scleroderma? I want to make sure the sites that I'm really looking at are the Mayo Clinic. What does the NLN have to say about? I want to make sure I'm looking at my trusted sites to make sure I'm getting good information. Because I don't know if I can trust some of the other sources.
What is that? Is it messed up skin?
It's an autoimmune disease that does attack your body in various organs. It attacks your your lungs, your skin, a bunch of other issues. It gives you a lot of issues. Scleroderma.
Cause skin miles.
Yep. Yeah. Word building. Yep.
Oh.
It attacks a lot of your connective tissues. Yeah. It's pretty gnarly. All right, let's go through. I think we're almost done with this. Okay, yeah, we are done with the menti. All right, so you could ask me anything in person. You can ask me anything on here. This part of this was just to remind you that everything that you put on the menti, it's all anonymous. So I can't ever see like who, if you ask a question or if you give a reaction or if you answer, I can't ever pull that. So it's all anonymous on here. So please feel free to participate fully in those because it's there's no judgment with it. Nobody knows what you said. No questions? Oh, yeah, go ahead.
No, in the last chapter, chapter 3, it was talking about ethical, principles and ethical theories.
Mm-hmm.
Is there a difference between those two, or do they like go hand in hand?
That's a really good question. Ethical principles and ethical theories. I think there's general ethical principles in like, hey, I don't want to do something that's going to harm my patient.
Right.
I don't want to say something that I know is a lie. There's also ethical theories that are like general thought processes, and I can't think of what they are right now. But we can look them up a little bit later. Yeah. All right, so done with the menti, just so you guys know, at the end of lectures, at the end of the day, I do post the videos that we're recording now. I also post a PDF of the menti as well. So if you want to go back through and review some of those things as well. So now I want us to break up and do a little bit of group work. Oh, we didn't do our KWL. So let's do our KWL now. So, and if you've already done some, that's totally fine. The KWL, let's do this one on evidence-based practices. So if you've already done more, it's totally fine. If you haven't, if you've already done it, it's totally fine. If you haven't, go ahead and take a minute and write out on evidence-based practices. What do I know? What do I want to know?
Pretty different.